Good day, everyone. I'm Dr. Ayla Edsmirjan Suidi Torres, and I'm here to discuss the epidemiology of tuberculosis. For the objectives, number one, to define what is tuberculosis and how is it transmitted. Number two, to discuss the global and local burden of tuberculosis. Number three, to recognize the signs and symptoms suggestive of tuberculosis. Number four, to diagnose tuberculosis and initiate its management. To show you how serious and threatening this disease is, here is an article about an incident that happened in 2014 in Texas, where health officials were alarmed when a number of patients were exposed to TB. This one happened in 2015 in Northern California Hospital, tracked down patients exposed to TB. And lastly, in 2018, Johns Hopkins Hospital researchers evacuated the hospital due to TB scare. These incidents show how scary and serious TB is in their country, and a complete opposite here in ours. So for a brief introduction of TB, it is an infectious disease caused by the bacteria called Mycobacterium tuberculosis. It is transmitted through coughing, sneezing, and spitting, and lungs are the most common site for the development of TB. To give you a quick history on TB, it started in 1865 when Jean-Antoine Villemin, a French physicist, proved TB to be an infectious disease. Then, Robert Koch, who is a German physician and one of the founders of bacteriology, discovered tubercle bacillus in 1882. And in this slide shows the other discoveries that led in the management of TB worldwide. Developed tuberculin skin test, the BCG, and other medications. And for the global burden of tuberculosis, according to the WHO, the World Health Organization, TB is considered as an epidemic and one of the top causes of mortality worldwide. Of the 10.6 million people with TB worldwide, 6 million are men, 3.4 million women, and 1.2 million children. And unfortunately, only 1 out of 3 people with drug-resistant TB had access treatment in 2021. Last 2022, the WHO released a global tuberculosis report. Since this is pandemic, they only have 2019 report. And according to them, TB ranked 13th for the top causes of death in 2019. Hence, the WHO had a vision of a world-free TB with the goal to end the global TB epidemic. And to achieve this goal, they have set indicators and targets up to 2035. For 2025, they wanted to have a 50% reduction in the TB incidence rate. However, they have 40% shortage from the target according to their data in 2021. They also wanted to have 75% reduction in TB death, but data in 2021 says that they're still 69% short. And lastly, they wanted 0% of people with TB facing catastrophic cost. However, data in 2021 showed that 48% of the TB patients spend money for their diagnosis and treatment. So this figure, on the other hand, shows that globally, most TB patients are males with age 25 to 54 years old. The question now is, how are we doing locally? Actually, a law was passed last 2016 in the Republic Act 10767, otherwise known as the Comprehensive Tuberculosis Elimination Plan Act. It is an act establishing a comprehensive Philippine plan of action to eliminate tuberculosis as a public health problem and appropriating funds therefore. So the Department of Health formed the National TB Control Program to lead the plan for the TB elimination, with the general objective to contribute in the achievement of case notification rate of 90% and treatment success rate of 85% targets of programmatic management of drug resistance TB or the PMDT in the NCR. In order to achieve the main goal of TB elimination by 2050, NTP set the 2035 targets of 95% reduction in TB deaths, 90% reduction in TB incidence rate, and no affected families face catastrophic cost. Data by the Philippine Statistics Authority in 2017 showed that 7 out of 10 leading causes of mortality are non-communicable diseases. These data also showed that TB ranked number 8. Data from DOH showed a steep increase of TB cases in 2021. And according to them, there are 650 cases per 100,000 population in 2021 from 580 in 2020. Again, data from the WHO showed that the Philippines is in the top 10 worldwide in TB incidence in 2021. In gaps in between, notification and relapse TB cases, and in incidence of MDR or RRTB. How about in case finding? It is the identification and diagnosis of TB cases among individuals with signs and symptoms presumptive of TB. Gene Expert is now the primary diagnostic test used for PTB and EPTB. Smear microscopy and the TB lump, on the other hand, is used as an alternative of Gene Expert if it is not accessible or available. Tuberculin skin test is used as an adjunct to help diagnosing TB in children. A result of 10 millimeters in immunocompetent patients and 5 millimeters in immunocompromised patients shows positive result. It is also reiterated by the DOH that only trained health workers shall do testing and reading of TST. So let us define the 3 case findings. So the first one is the intensified case findings. This is a screening of patients, who go to health centers, while active case finding is when health workers do screening outside health facilities. So a good example of it is when you have a medical mission. So on the other hand, enhanced case finding is when health workers do house-to-house visits to screen patients for TB. How about the presumptive TB, close contact, and the children? So presumptive TB is defined as a person having at least 2 weeks cough, remember 2 weeks cough, unexplained fever, unexplained weight loss or night sweats, or if the patient has a chest x-ray result suggestive of TB. The close contact is also a person who shared enclosed space for extended periods within the day with the index case during the 3 months before diagnosis of TB. And the children, remember, the age is less than 15 years old. So how do we classify a TB disease? It is based on bacteriological status and based on anatomical site. So a bacteriologically confirmed is when the sputum sample submitted by the patient yielded positive result. On the other hand, clinically diagnosed is when a patient does not fulfill the criteria for bacteriologically confirmed but diagnosed with active TB by a clinician. It is usually based on the chest x-ray result and more importantly on history and physical exam. And according to anatomical site, TB can be pulmonary or extrapulmonary. And lastly, based on the history of previous treatment, a patient is classified as a new case if he or she never had previous TB treatment or on TB drugs for less than a month or 28 days. So a month is defined in NTP as 28 days. Otherwise, he or she is classified as retreatment. For the identification of presumptive PTB, so as I have mentioned earlier, a patient complaining of at least 2 weeks cough, unexplained fever, unexplained weight loss, or night sweat should be tagged as presumptive TB. Request for a gene expert, and if the result is positive, we can now classify the patient as bacteriologically confirmed and should immediately start treatment. On the other hand, if the result is negative, a physician can request for a chest x-ray. If the chest x-ray turned out to be positive, the physician should use his or her best clinical judgment based on the history and physical examination to diagnose the patient as clinically diagnosed TB. For patients living with HIV, it is warranted that they will also be screened for TB. Symptomatic screening chest x-ray are done, and if positive, gene expert is requested. For the sputum collection, so for the gene expert, on the spot sputum sample amounting to at least 1 ml, and on the other hand, sputum microscopy required two sputum specimen samples amounting to 3 to 5 ml. Now we have the spot, 1 hour apart, only 1 day, and spot early morning specimen 2 days. Specimens should be collected in a well-ventilated area, and the only contraindication for submission of sputum is massive hemoptysis, which is defined as 200 to 600 ml of blood in 24 hours. And blood-streak sputum can still be examined. For the diagnosis, gene expert can have 5 results. MTB detected with no rifampicin resistance T, MTB detected with rifampicin resistance RR, MTB detected rifampicin resistance indeterminate TI, MTB not detected N, and I, which is invalid or no result or error. Usually, the positive result showed in red ballpen. So, if the result is T, immediately start the patient on TB treatment regimen. If the patient's result is RR, identify first if the patient is high risk, meaning he or she is a retreatment case, or if he or she is a contact of confirmed MDR, RR-TB case, of or if he or she belong to high risk group like the inmates, children, elderly, or has diabetes, the mnemonics eyes. If yes, work up the patient before starting RRTB treatment regimen. And if not, do another gene expert and follow the second result. This is also what to do to patients presenting with indeterminate resistance and invalid result. And for those with gene expert, result of not detected but you are still suspicious, you may do antibiotic trial first or chest x-ray. For patients less than 15 years old, decide if you start them on TB treatment regimen if he or she fulfills 3 out of 5 criteria. This is the 3 out of 5 criteria. Positive exposure, positive TST with signs and symptoms, chest x-ray suggestive of TB, or have other laboratories suggestive of TB. If less than 3 out of 5, investigate. If at least 3 out of 5, clinically diagnosed TB. And then for intensified case finding, screening of household contacts is warranted. So if the index case is DSTB, chest x-ray is needed for contacts with age of at least 5 years old. Gene expert is also needed. And if active TB is ruled out, consider starting TPT, the TB preventive therapy. However, if the index case is unknown, DRTB, all household contact, regardless of age, is required to do chest x-ray and gene expert. And if TB is ruled out, TPT is not recommended. For the case holding, and as previously mentioned, patient is a new case of if he or she did not have any history of previous TB treatment or has taken it for less than 28 days or 1 month. For retreatment, we have 4: relapse, treatment after failure, loss to follow-up, or previous treatment outcome unknown. So relapse, if the patient is previously declared cured or treatment completed and is presently diagnosed with bacteriologically confirmed or clinically diagnosed. Treatment failure, if the patient has smear positive in the 5th month of treatment. Lost to follow-up is when a patient is lost to follow-up for at least 2 months. And finally, previous treatment outcome unknown is when a patient cannot remember the outcome of his or her recent TB treatment. The first line, anti-TB drugs. So regimen 1 is used for all new cases of PTB or extrapulmonary TB except the CNS, bones, and joints. And patients should take 2 months of isoniazid, rifampicin, pyrazinamide, and ethambutol for the intensive phase, and 4 months continuation phase of isoniazid and rifampicin. For the regimen 2, it is used for new cases of extrapulmonary TB of CNS, bones, and joints. It differs from the regimen 1 in the continuation phase, which lasts for 10 months. Okay. So a fixed dose combination is given to patients with TB. The number of tablets a day depends on the weight of the patient. So this table shows the number of tablets a day for both the intensive and continuation phase based on the patient's weight. So on the other hand, this table shows the tablets per day for patients less than 15 years old. So for the monitoring treatment response, initial follow-up is 2 weeks after treatment initiation and at least monthly thereafter. So always ask the patient for the resolution of their signs and symptoms and if they experience any adverse drug reaction. So that is very important. It is also reportable. We should also manage their other comorbidities. And getting the weight of the patient is also important because weight gain may be used as an indicator that the patient is improving. Okay? So a follow-up smear microscopy is also important. If the patient is clinically diagnosed, do the smear microscopy at the end of the intensive phase. If the result is negative, no need to repeat it. But if the result is positive, continue the patient on the continuation phase and repeat the smear microscopy after the third month, which is the first month of the continuation phase. If the result is negative, no need to repeat the test. But if the result is still positive, tag the patient as treatment failure and second-line drugs are considered. So for patients who are bacteriologically confirmed or retreatment cases, smear microscopy is done 3 times. So at the end of the intensive phase, at the end of the 5th month, and the 6th month of treatment. So when should we clear the patient? You can clear a clinically diagnosed patient after 1 week of uninterrupted treatment. However, for bacteriologically confirmed cases, you may do smear microscopy at the end of the 2nd week of treatment and clear them if the result is negative. So 1 week and 2 weeks. For treatment interruption, if the patient had treatment interruption for less than 1 month, he or she will continue the treatment and prolong to compensate for the missed doses. If the patient had treatment interrupted for more than a month but less than 2 months, do a smear microscopy. If the result is negative, we can continue treatment and prolong to compensate. However, if the result is positive, it is important to know how long has patient has been treated. If it is less than 5 months, continue treatment and prolong to compensate. If the patient is already at least 5 months on treatment, we should tag him or her as treatment failure. And lastly, if the patient had at least 2 months of treatment interruption, he or she is already lost to follow-up. And for the last part of our lecture, the treatment outcome. Cured is when a patient completed the treatment regimen with a proof of smear negative result at the end of the last month of treatment. A patient also completed the treatment regimen for treatment completed. However, patient has no result of a negative smear on the last month of their recent treatment. Treatment failed if the patient still has smear positive on the 5th month of treatment. Lost to follow-up is having treatment interruption for at least 2 months. Dies if when a patient dies for any reason during the course of treatment, whether it is TB related or not. And lastly, not evaluated if the patient has no treatment outcome assigned. Okay? With that, I hope you learned something this afternoon and thank you for your kind attention. Thank you.